Thank you for joining me today. I'm Boban Nadokov. This is for Nursing 4401 Healthcare Policy, Dr. Rebecca Cooper of Centenary University. The healthcare policy critique today will take place for the bill Workplace Violence Prevention and the Healthcare and Social Service Workers Act. This bill intends to address workplace violence, which is a persistent and rising threat in the U.S. healthcare system. The most frightening part of this statistic is the simple fact that it continues to rise with no impotence. Healthcare and social workers have actually experienced the highest rate of non-fatal workplace violence nationwide, according to reporting from the National Institute for Occupational Safety and Health in 2024. This includes police officers. The purpose for this is to present a critique of the policy, see how we can implement the policy, what it means for the finance of the healthcare systems, what it means for administration, what it means for the practitioners, and what it means, and most importantly, for the person seeking healthcare in our system and their outcome. So the policy, as it officially is enumerated, is H.R. 2663 in the House of Representatives and S in the Senate 1176. It establishes mandatory OSHA violence prevention. Previously, we've only had guidance from OSHA, starting in 1996. It intends to do this through policies and key provisions, which we will cover shortly. This policy wants to create consistency across a federal body with enforceable standards, which we have lacked thus far. It applies to hospitals, psychiatric facilities, emergency departments, long-term care facilities, home health, and social service agencies, essentially covering a very broad spectrum of healthcare's most vulnerable employees. The needs for this arise from long-standing evidence that voluntary measures are insufficient in creating an equitable safety standard. And under this bill's direction, the Secretary of Labor will ensure that all covered employees, including these facilities and their providers, will develop and implement comprehensive workplace violence prevention plans. The key policy provisions include comprehensive hazard assessment. Until now, all data collected has only been collected from states which have implemented mandatory proceedings, which we'll cover shortly. This data correlates most closely to what we intend to do, as the federal bill was predominantly devised based off of the way that these bills have been standardized within the states that have them. The key to these mandates are hazard assessment, employee training, incident documentation, post-incident support, and worker involvement in safety planning. Standardized incident reporting systems will create a data aggregation system that we can actually utilize to create a metric of safety that is accurate and not dependent upon internal facility reporting, which may be done inaccurate and is more susceptible to being skewed in the favor of finances. Mandatory staff training and annual evaluations to ensure all employees have equitable training. Employee participation in the creation of the violence prevention planning to ensure that all employees of all levels have a voice, are able to contribute their experiences, and create a system which protects everybody equally. OSHA enforcement and compliance oversight to ensure that there is a federal body which will provide the oversight need to regulate this and ensure that every level is covered. The origins of the policy stem from workplace violence, which has been escalating throughout the decades, and especially post-pandemic. As previously mentioned, some forerunner guidelines were established by the Federal Agency for Occupational Safety and Health Administration, OSHA, back in '96 and 2015, but these remain voluntary and are not sweeping across the board. the majority of states, 47 in fact, have not standardized these. They remain non-mandatory and lack enforcement. The mechanisms which lead to protection are inconsistent, and therefore they are underreported and inadequate in the majority of situations, as per O'Brien et al. In 2024. Worker advocacy groups, such as nursing groups, unions, federal injury data, it's all driven legislation, but unfortunately has been unsuccessful to this long. Let's see here. The implementation status. Although we're repeatedly introduced since 2018, the bill remains non-enacted. No official standard exists, just as we said, the OSHA guidelines. States such as California, Washington, and Oregon have their mandatory laws, and that is where we'll be drawing the most of our data, due to their close relation and being the inspiration for the formation of this federal bill. The current environment remains fragmented at best and ensures that every facility that you go to will provide a completely different level of safety, which makes it difficult to continue to do your job, and it is ineffective in guaranteeing the basic expected rights of safety at facilities when you're working as a healthcare provider. States with mandated prevention plans, as we said, like California, for example, being the preeminent one, have reduced violent incidents. They have fewer injury claims and lower absenteeism of staff. It most closely resembles the proposed changes of HR 2663 and is modeled most closely to those existing OSHA practices. These jurisdictions show a meaningful development of the plans that we intend to implement, and therefore can provide driving data to support federal legislation. O'Brien et al. 2024 noted the structured program significantly decreased violence. Evidence under voluntary systems, healthcare workers continue to experience the highest rate of non-fatal violence, as we said previously, by NEOSH 2024. This evidence, to the contrary, demonstrates that if we do fail to enforce a federal standard, we will continue to propagate a system in which violence and injury is running rampant through our healthcare facilities, preventing equitable healthcare for all individuals, and diminishing patient outcomes through lack of providers, lack of staff, staff losing time from work, finances being spent to cover inexcusable and avoidable injury. Multi-state review confirms this hypothesis. Some of our barriers are, again, underreporting. Because there is no standardized reporting system, healthcare systems can report what statistics they'd like to report, and it's entirely reliant upon their internal reporting system. For example, my hospital currently utilizes a reporting system known as Origami, previously ClearSight. Both ClearSight and Origami have their benefits, but they also lack in several different venues. They do not have a standardization across different hospital systems, and therefore what my hospital reports, what the system reports, and what other health systems report could be something that is incomparable and does not properly support the prevention of workplace violence accurately. Resource limitations in rural areas and safety net facilities also propagate this issue, as those facilities are not able to report as accurately. They're not able to record the same, and they might not have in place the same reporting procedures. As such, data which could support the vast disparaging gap of safety for employees gets lost and not recorded properly. The inconsistent program adoption without federal mandate just contributes to this, as we've stated multiple times now. We also lack unified effort. As much as employees have got together, organizations have got together, there has not been a structured enough push with enough support from the public, and that is probably the most effective way to get this bill federally passed. We must ensure that the public is aware of the consequences for all individuals, not just healthcare workers, and facilitate a much bigger, much bigger draw of attention to this bill. And it will assuredly be passed with the data given, even as presumable as it is. On the other side, we have the financial considerations. RN turnover costs, according to NSI in 2025, equate to approximately $60,000 per nurse. That's lost wages and training from nurses leaving. I personally worked in security prior to becoming a registered nurse, and I can first-handly see the expenses of each facility when it comes to workplace violence payouts. And facilities which are similarly sized and staffed, because of different standards in the single variable of safety standard enforcement, have completely different expenditures when it comes to workplace violence payouts. For example, one facility in the network had a year of only $69,000 in payout, where a similar sized facility with similar staffing paid out over $5 million in workplace violence due to different implementation of safety measures and workplace violence prevention programs, even within the same health system. This healthcare violence or workplace violence drives turnover. It drives absenteeism, compensation. It leads to burnout, leads to injuries. People do not want to go to work if they're risking their lives in a situation in which they shouldn't be, while they're trying to save other people's lives. Prevention programs are less costly than injury-related consequences. If you are going to look at the amount of money spent and then estimate how much money it would cost to implement a standardized workplace violence, in the long term itself, it's a no-brainer. Workplace violence implementation will be cheaper. But the variability of yearly expenditures due to workplace violence injury is where we cannot have a direct data-driven example, and that is the problem, because prevention of workplace violence doesn't demonstrate the amount of money saved. One can only assume the amount of money saved off of the decrease from previous year's payouts, which is too variable and truly doesn't account for how much money is hypothetically being saved. But it is assured in the amount of staff availability, staff retainment, and lack of staff out due to injuries. The effect on healthcare services is pretty obvious. Increased turnover disrupts continuity of care. Higher risk in units that actually experiencing shortages in is way more critical to the patient outcome, like the ED. The ED is short, that's going to result in a lot more poor patient outcomes. Reduced access and longer wait times. Workforce instability lowers quality in patient care. There isn't a transfer of knowledge. There isn't time for people to master their profession, and whether it's nurses quitting the profession or switching to different types of care, these areas are disproportionately affected, and that disproportionately affects certain groups of individuals who require this specific type of healthcare. If we look at statistics from O'Brien in 2024, we can even see that healthcare workers are killed in their workplace from 2011 to 2018 in the U.S., averaging about 20 deaths per year. Would that make you feel safe coming to work? As I said just now, it also impacts marginalized populations. Safety net facilities are disproportionately affected. Underserving communities which experience greater disruptions in care, underserved communities. There's turnover and injury. It reduces service availability, and this usually affects facilities in more rural areas with more specifically populations that more specifically get affected. Policy enactment may enhance equitability by stabilizing high-risk facilities, the same facilities we listed before, such as the emergency department. And, urgent cares, for example, more rural urgent cares especially. The application to the advanced practice nurse, well, APNs statistically are at the highest risk in as they work in these environments. They're frequently staffed in the high-risk environments such as the emergency department, psychiatric units, primary care, correctional facilities, and home care. And these settings happen to also disproportionately have elevated rates of workplace violence occurrences, according to OSHA in 2024. They can also lead training, reporting, and quality improvement initiatives as they're first to the scene. They're the ones that are experiencing the brunt of all of this, and therefore have a unique opinion that can be utilized to actually properly structure these workplace prevention acts. As we talked about before, this would ensure that all employees are able to speak to what would best suit their practice going forward. Beyond the clinical function, APNs are uniquely positioned to influence the successful implementation of violence prevention programs. As they are most affected by them, they can speak to their administration and the efficacy of them. Aside from the data that we aggregate, they also have interpersonal leadership skills which have been developed through years of practicing, and they can help to motivate team members with less of a voice to speak up, and that way we can accrue the data we need. The Act enhances the APN's ability to deliver safe and uninterrupted care. This is probably the most important part of this, because remember, the whole point of healthcare is to not only do no harm, but to deliver the best outcomes for our patients. And that is severely diminished when we're lacking in staff, we're lacking in experienced staff, and staff do not feel safe coming to work. APNs can utilize their policy competencies to engage in organized behavior in committees, testifying to the legislative process, participating in professional organizations such as the American Association for Nurse Practitioners, and these are the organizations that need to push for this legislation with a unified front. The application to healthcare administration is even simpler. Administrators are responsible for compliance, implementation, and resource allocation. This makes their job easier. It will initially be a burden, but a burden spread amongst all employees, and then it will save them money, time, and effort going forward, and they will no longer have to deal with the additional burden of managing all of these injuries. Violence prevention plans reduce liability and exposure, data reporting improves organization oversight overall, investment in safety improves retention and organizational resilience. Implementations for the future include national standardization of the violence prevention practices, improved retention and decreased injury rates leading to better staffing. This shift will produce implementation similar to those observed in the existing states with the same results, most likely, which are all beneficial to the practice. Greater safety in high-risk units, leading to better functionality, enhanced health equity for underserved populations, and increased use of technology, alert systems, analytics, adding to a different economical aspect. In conclusion, the policy for workplace violence prevention helps to address a preventable issue, and it hopes to do this through required federal action. The Act establishes evidence-based protections for workers and patients, most importantly, because this does especially affect patients. In the end result, national adoption would improve safety, retention, and health equity, as we've seen in states that have made it law. And going forward, implementing this across the board can almost assuredly guarantee that overall the healthcare system benefits financially. The healthcare system benefits in that it becomes a better environment, drawing better workers in, drawing a bigger population, removing worker shortages, and evolving into a system that runs more smoothly, effectively, and has better patient outcomes, which is the goal of the healthcare system overall. And it all starts with implementing this policy and making changes required to ensure the simplest of things, safety at the work environment. Thank you for your time. These are my references. Have a good night.